Good morning, everyone. I want to welcome you to Grand Rounds today. We have a very interesting topic that's near and dear to my heart with two excellent speakers. So they gave me about 45 seconds to introduce them. I asked for an extra 15. And with that, I'm going to try to give you a brief history of the care of congenital heart disease at Children's Hospital over the last 75 years. In 1950, sometime in the 1950s, the first open heart repairs were done by Dr. Robert Pontius, who was one of the earliest surgeons to do any heart surgery. In 1960s, the cardiology department was developed. The first and only pediatric cardiologist at first was Dr. Richard Bowersfeld, who was actually trained at the first training program in pediatric cardiology by Dr. Helen Taussig, who is a renowned icon in pediatric cardiology, and her program at Johns Hopkins. Dr. Bowersfeld was a great clinician, but his passion really wasn't congenital heart disease after a few years. But one thing that he did that was really a critical part of our history is that he recruited Dr. Zuberbuehler to be in pediatric cardiology. And Dr. Zub started the program really and started recruiting people. And one of the early recruitments was Dr. Henry Bonson in 1963. Dr. Bonson was trained by Dr. Blaylock, who was one of the first pioneering surgeries in congenital heart disease. And Dr. Bonson traveled with him all over Europe during one of the first palliative procedures, doing a shunt, a Blaylock-Taussig-Thomas shunt. And in those early years, Dr. Zub and Dr. Bonson established a bond that has continued and grown to this day, with mutual support and friendship between the cardiology group and the surgical group. And anyone that knows anything about congenital heart disease knows that either group can only go as far as the excellence of the other. In 1970 through 1990, there was a rapid expansion of care for the care of complex heart disease in infants and children. Heart transplants were done. And the person who led that effort was Dr. Ralph Sewers. He was one of Dr. Bonson's first residents, and he became director of CT surgery at Children's Hospital for over 20 years. One of Zub's legacies in the 1980s and 1990s was to establish a close relationship with adult cardiology. He was very good friends with Jim Shaver, who was a leader of UPMC adult cardiology for many years. And that connection between Zub and Shaver really started the interest in adult congenital heart disease. So it ties in very well today with the second part of our Grand Rounds, where Dr. Hoskoppal will be talking about that subspecialty of adult congenital heart disease. In 2004, the baton was passed. Dr. Sewers retired, and we were very fortunate to recruit Dr. Morell, who remarkably looks pretty much exactly the same as he did back in 2004. Dr. Morell is a native of Puerto Rico. He did his residency in Pennsylvania, Massachusetts, but his key training was in congenital cardiac and thoracic surgery at two of the great institutions in this area, Boston Children's Hospital and Great Ormond Street in London. His first job and his only faculty position before he came here was at St. Joseph Hospital in Tampa, Florida. And in those 4 years there, he established a national reputation as being an outstanding surgeon. So we were very fortunate to recruit Victor to Children's Hospital in 2004. He has accumulated a number of titles that start with chair, chief, division chief, co-director, director, executive director. There's so many of them that it does fill up an entire slide, and I left out the second one. But the important thing is that he is now chief of cardiothoracic surgery throughout UPMC, both adult and congenital, co-director of the Heart Institute at Children's Hospital, and I have to believe this is where his true passion lies, in this hospital. Dr. Morell, over the last 20 years, has shown a remarkable leadership and growth of the care of congenital heart disease, building on the work that was done before him. His surgical skills are outstanding, but his other talents in administration, teaching, and research, and probably most important, is his camaraderie, collegiality, and team-building spirit that has been instrumental in making the division here in the Department of Cardiology and Cardiac Surgery one of the top in the country. Now, if we move on to our second speaker, I'm going to introduce now so I can leave and I don't have to sit around all Grand Rounds. But no, that's not true. As I said, the specialty of adult congenital heart disease evolved out of the excellent care that cardiac surgeons and cardiologists were doing. And these children who had complex heart disease grew up and became adults with other issues. And so a very important subspecialty developed, and Dr. Hoskoppal was in that group. And we were very lucky to get him here. He was trained in cardiology at the University of California, San Francisco. He was unfortunately indoctrinated to be a San Francisco 49er fan, which is about the only negative thing I could think to say about him. I know this isn't a roast, but he did his adult congenital heart disease training at Mayo Clinic and was on the faculty at the University of Utah for 5 years. And again, we were extremely fortunate to recruit him here to direct our adult congenital heart disease. He works at several clinical sites, Children's Hospital, Presbyterian Hospital, Hammett Medical Center, and also McGee, which I didn't list. His special interests, co-director of the aortic clinic, cardiac care and pregnancy. He's an enthusiast of indoor and outdoor sports. I'm not sure what the indoor sports are, but I know he has a passion for golf. And Dr. Hoskoppal has done a great job and extended that collegiality that Dr. Morell always showed to develop the adult congenital heart disease program. So with that introduction, I'm going to turn it over to Dr. Morell.
Thank you. Thank you, Lee. Obviously, we all know Lee Bierman and talk about collegiality and collaboration, and we couldn't do any better than Lee Bierman as our chief of EP, who's been for a long time, and as a friend. And I have to say, the three of us share the love for golf, and that helps us stay, friends, not in the golf course, but outside the golf course for sure. Yeah, can we get out of it? So my intent is just to give a quick history, and some of what I said, I didn't realize that some of my history on Pittsburgh, Lee has already given, so thanks for doing that. Collegiality, so good you already gave my talk to a point. But is that being shared? Okay. So I'm going to talk a little bit about the mythology as it relates to the heart, the history of congenital heart surgery, and the current management and outcomes of congenital heart surgery. Aristotle, brilliant man, thought that the most important organ in the body was the heart, and I think some of us still believe that. He thought it was the seat of intelligence, motion, and sensation, and the center of vitality. And I think he was on it. I think culturally, we all still believe that the heart is the most important. As you can see, you transplant the heart of a killer into somebody else, and the other person becomes a killer. So it only makes sense. I look at this picture, I yet don't know who's the donor and who's the recipient, though. But anyway, that's how we feel about the heart. If we look at the history of how the knowledge related to heart disease came about, these are some of the first books ever published on childhood illnesses. And you can see out of over 1,000 pages, there were only 7 pages or 5 pages dedicated to congenital heart disease. So there was very little known about congenital heart disease. We knew a lot about many other things, but not much about congenital heart disease. 1936, Maud Abbott publishes this book based on past specimens, unfortunately, because you really couldn't make any diagnosis. You only make diagnosis that patient was dead. And I have a copy of this book in my library. If anybody's interested, it's a tremendous book. And what's still interesting is some of the stuff that is in that book is still relevant today. Okay, some of the stuff that she describes in this book still exactly what we look for in physical examination and in X-rays, stuff like that. So we progress a lot, and we still haven't. Robert Gross was the first surgeon who ever did sort of a congenital procedure, which was a PDA ligation in Boston. We consider that a closed procedure, so it's not a really open heart procedure, but it's a closed procedure. It was the first ever done in 1938, and at that time, that was a big deal. This is a typical patient in our NICU, and I have to say, years past when before all my great partners who, I don't do PDAs anymore, but at least in the NICU, but I think most of us don't do PDAs anymore, simply because we've gone away from doing thoracotomies and the field had advanced, and we have advancements now. And obviously years ago, we started occluding in bigger kids, the PDAs with devices, so non-surgical patients. And now even for the most premature patients, they go to the cath lab and they have what's called a piccolo occluder device installed. So we rarely, if ever, have to go to the NICU anymore and do an open procedure, which again, as a surgeon, so I missed those cases. They were fun. They were, these little munchkins that we're gonna, quickly get the procedure done. Now we don't do those cases. Crawford in 1944 describes repair of aortic coarctation. We still do, I have to say, thank God, we still do coarctation repair surgically in little babies, newborns, infants. But as they get older, and as you can see here, and this is an older patient with a native coarctation that was not diagnosed early. And now they go to the cath lab, and some of these patients get a stent placed, and we don't need to operate. Okay, so again, advancements in technology, in intervention, taking some of our cases away. Helen Brooke Tausig develops from Johns Hopkins, looks into tetralogy of Fallot, and she realizes that if you have a cyanotic neonate with tetralogy of Fallot and the duct disappears, patients die. If you have a non-cyanotic patient with tetralogy, the duct closes, the patient becomes cyanotic. So she goes like, okay, well, this is a great idea. Why don't we create a PDA to treat those cyanotic patients? She goes to Robert Gross, who was occluding PDAs, and said, why don't you help me create a PDA? And he tells her that he's not in the business of creating PDAs, he's in the business of closing PDAs. So he goes to Alfred Blaylock at Johns Hopkins, and he's interested. And, the BTT, obviously Vivian Thomas, we know that it was the person behind the development of this. So we call it now the BTT shunt. But that's another procedure that is becoming less and less common because now we have PDA stents. And now patients go to the cath lab and have a PDA stent. And I will tell you, over the last 5, 6, 7 years, we only do basically shunts on patients for Norwoods, and the typical cyanotic patient who needs a shunt, if possible, they usually go to the cath lab and get a procedure done in the cath lab. And, this is the COMPASS trial, where one of the sites that is comparing BTT shunts versus PDA stents. But I have to tell you that when we speak to families and say, we have this study, you want to participate, it's either a surgical procedure or going to the cath lab and getting a stent. They say, no, I would rather go to the cath lab and get a stent. So we've had a really difficult time enrolling patients because obviously the stent is more sexy than surgery. John Lewis in 1952 describes or performs the first quote unquote open heart procedure, which was an ASD closure. And you can see how many people, this is the true picture from that operation. You can see how many people are around that table. It's incredible, the number of people there. He did it with moderate hypothermia, in which pre-op, they would put the patient in a basin and they would pour ice on top of this patient under anesthesia, and then to put him on a table. And then under inflow occlusion, he would occlude the SVC and IVC, open the heart with a beating heart, put a finger, feel where the hole was, and sort of blindly put sutures in there. And obviously there was a mortality. He did the first 33 patients, he had a 12% mortality, which you can argue with that, a medieval procedure, 12% mortality is quite impressive, but clearly not what we do today. Another procedure that has disappeared from, or mostly disappear from my operating table is ASD closures, because these patients usually go to the cath lab and have a little device put in and everybody's happy and we don't do surgeries. Then we have the heart-lung machine. Okay, so the heart lung machine was developed by David Gibbons, 1953. You can see there's a monstrosity of a machine. It was extremely toxic for the patient. He did an ASD, so he was competing with Lewis. Lewis was doing inflow occlusion and hypothermia, and he developed this machine. And he's doing, unfortunately, the first 6 patients he operated, 5 died. So compared to Lewis, this machine was no good. And he ended up quitting doing open heart surgery because he was so distraught by his outcomes. But the heart lung machine is an incredible machine that without it, we couldn't do most or pretty much everything. I mean, we do everything with the heart lung machine that is open heart. And it's a great machine. You know, you pull, you usually put, in our world of pediatric cardiac surgery, in which we work inside the heart, we have a cannula in the superior vena cava, a cannula in the inferior vena cava. We suck all the blue blood into this venous reservoir. Then it goes through an oxygenator. It turns into red blood, gets pumped under pressure into the aorta, and it allows us to work inside the heart for hours. Okay, so obviously we have to stop the heart. We give a solution, cardioplegia, which is a high potassium solution, stops the heart in diastole, and we're able to work in there, and it's revolutionized what we do. The father of cardiac surgery is Walton Lillehei. He was at University of Minnesota, and he developed the techniques for the repair of VSD, tetralogy of Fallot, AV canals, mitral valve repair. He also was instrumental in developing mechanical valves. So Medtronic came out of also Minnesota. It was with his influence. And I'm sorry, St. Jude and Medtronic, obviously a pacemaker, same thing. He had patients who developed heart block after operations, and he had them hooked up to electricity with external pacers. Unfortunately, one Halloween, electricity went off in Minneapolis, and there was a patient that was hooked up to the wall, basically, and with no electricity, the kid died because they couldn't pace. And so then he worked with one of his repairmen, developed a battery-run pacemaker, and that's how really Medtronics came to be. He also developed this operation, which was cross-circulation, in which you would use the parent as the bypass machine, which is incredible. It's very thoughtful. Obviously, the parent will correct all metabolic issues and get perfused to the kid, but this is the first operation developed by mankind that could have a 200% mortality as opposed to 100% mortality. And it never happened, though. There was never a 200% mortality with this operation. Clearly, the heart-lung machine did develop and did become the standard, and obviously all these older procedures went by the wayside. I just wanted to mention, you know, with tetralogy of Fallot, one of the earlier open heart procedures developed, we create pulmonary insufficiency. And it's been shown, and I'm sure that maybe Arvind will touch on that subject. And we've developed, again, technology that can, this transcatheter pulmonary valves that can be delivered through the groin into patients and avoids open heart surgery. So another advancement in the care of these patients that has revolutionized the care of these patients and avoids open heart surgery. Aldo Castaneda is the father of neonatal and infant surgery at Boston Children's, and he really pushed the envelope in the United States and worldwide for us to do early repairs and avoid palliative procedures. This is a classic example of what happened when you look at transposition of the great arteries. And you can see here that we started doing atrial switch procedures in which we basically rerouted the flow of the venous return so that we would put the systemic IVC and SVC into the left ventricle. So that you will have a left ventricle pumping into the pulmonary circulation, and you would then reroute the pulmonary veins into the tricuspid valve and allow the right ventricle to be the systemic ventricle, which is not meant to be, and they fail over time. In the 1988, 1990, the arterial switch operation became the procedure that we did. You have to understand that we went from the mustard to the Senning, which are two atrial switch procedures. And by the time we started doing the arterial switch, the mortality of descending and demonstrate was almost zero. And we started doing the arterial switch, and the mortality of the arterial switch was super high. So we had an operation that basically guaranteed the survival of your child, but we knew that long-term was going to give him issues. And we opted to, unfortunately, have a learning curve to learn how to do the arterial switch, how to take care of those patients, to then provide them a true anatomic repair and hopefully improve their long-term outcomes, which in this paper it did. The arterial switch has much better long-term outcomes than the Senning and the Muster, okay? So I'm not sure that in today's world we could do this experiment. I'm not sure that ethically we would be allowed to do something like that, even though it proved to be the right thing. So Lee covered what happened here. Just an important point, when Pontius came, and he was, when I came in 2004, Dr. Pontius will show up to conference. He showed up to conference until probably 10 years ago. And he always had comments, and he was a very colorful guy. He was married to one of Robert Gross' daughters. I didn't know that fact. I learned that just a few weeks ago. Obviously, Dr. Bonson came. Here's a picture with him, with Dr. Blaylock. He was one of the true surgeons behind who helped develop the BTT shunt. Obviously, Zub, crucial part to what we are here today. He's a visionary. His collaboration with Bob Anderson has been incredible too. Just an incredible guy. And obviously, we can't forget there are a bunch of other people here, and this is a crucial. One of the Children's has always put out, and the cardiology department has always put out some really crucial papers in the management of congenital heart disease. And obviously, we can't forget Sam Park and his contribution of the blade atrial septostomy and what he did for the care of patients with transposition of the great arteries. Okay, and obviously there are a bunch of names there that people can recognize who've been crucial to what's happened at Children's. This is a recent paper published in Circulation looking at, in Norway, obviously it's a very contained population. Everybody kind of stays there. They have almost, in this paper, it's the whole population of Norway, which ain't that much congenital heart disease, but they follow them forever. They don't move, they stay in Norway. And you can see what's happened to the mortality, especially in the little kids over the years. It's significantly improved. And this is what's happened here in the States too. But it is important to understand that what we do with quote unquote repairs, there's a significant number, especially when we get into more complex issues, cardiac issues. We have a lot of repeat customers. And that is a very important concept that we always say, well, we did our repair. Well, did we really? We put patches. I always tell families that I'm going to put patches, but your child still has the same defect he had. I'm just doing plastic surgery on the heart so that the blue blood goes where it's supposed to go, the red blood goes to where it's supposed to go, but there's still issues in the heart that maybe long-term will come and need other interventions. This is the landscape here in the United States. We have 153 hospitals in 39 states, and you can see the distribution. It's amazing when you look at the West and those center states in which there really obviously there's very little population, but some patients need to travel long distances to get any type of care. Even more interesting is when you look at those 153, the majority at hospitals, over 50% of hospitals do 100 cases or less. So, there's always been the debate, which you could argue, especially for complex procedures, that volume does make a difference. And in this paper, what they concluded was that maybe fewer hospitals with, more high volume, high quality hospitals might improve care, especially here in the US. And this is important because I'll be honest with you, I have friends of mine who've unfortunately appear in CNN. And you don't want to be in CNN. And there is a significant push in our societies to have transparency and for families to understand where they're going, and so that they know they can, quote unquote, shop around for the best care for their kids. The Congenital Heart Surgery Society has STS, has public reporting. We public report. Pennsylvania, many years ago, we knew that the state was eventually going to have some type of reporting. They had it for the adult cardiac surgeons. So all the congenital surgeons from the state, the different programs, approached the state, and we say, let's do this. But let's do it with good data. Let's get data from the STS, not some administrative data from Harrisburg. Let's look at the real data and publish it. So we have a collaborative way in which we want to make sure that the public knows. How much the public looks at this, I have no idea. Okay, but it's out there. These are some of our outcomes, and you can see we've pretty much mortality. It rarely happens. The STS national benchmark is about 2.5%. Okay, so mortality is some that we obviously haven't gotten rid of, but it's quite low. And mortality, it's not our major concern when we deal with patients. It's maybe more morbidity. And how has this change happened? I think it's crucial. I mean, what we have here at Children's, it's a collaboration between cardiology, cardiac surgery, cardiac anesthesia, cardiac critical care, and all these physicians are subspecialized in the care of cardiac kids. Okay, they don't do it part-time, they do it full-time. We also have dedicated cardiac nursing, dedicated cardiac perfusion. We have interventional or dedicated nursing and techs. So we have a very dedicated team of people who do this. We do this every day, 24/7. And I think that allows us to provide outstanding outcomes. And obviously with the support of all the subspecialty outstanding care that we provide here at Children's, allows us to provide outstanding care to our kids. And this is my final thoughts. The care of patients with congenital heart disease has significantly improved over the last 80 years. We have very low surgical mortality, but patients with repair congenital heart disease need continuous medical care. And this is why my colleague, Arvind Hoskoppal, is going to come here and talk, because like I said, we're getting rid of a lot of the mortality. So all these patients are surviving. So what happens to them when they become adults? It's become a big issue, and Arvind's going to talk about this. Thank you so much.
Thanks, everyone, and thanks for this opportunity. While I bring up my slides, there are going to be a lot of overlapping themes between what Victor said and what I'm going to say, obviously. But let me warn you in advance, I tend to get a little philosophical, so that's going to be the difference. If that's not your thing, I apologize in advance. Anyway, and thanks for the wonderful introduction, Lee. And he gave us a great overview of congenital heart disease evolution in the Children's Hospital of Pittsburgh. What he left out was that he was one of the pioneers of taking care of adults with congenital heart disease. And I'm truly honored to be working with you, Lee, and you're a great physician, great human, and a mean golfer, to be quite honest. And he has some mean jokes on the golf course, so and be careful if you're golfing with him. I've learned a lot from you, Lee. And one thing I learned is you don't teach by preaching, you teach by setting an example. And one of the life lessons I learned is take your work seriously, but don't take yourself seriously. So thank you for everything you've done and continue to do here. So the questions of the day: why does ACHD exist as a specialty, and why do we still take care of adults at the Children's Hospital? And hopefully I'm going to try and answer those questions with some examples of some cases and some lesions. We have all seen this photograph in most congenital heart disease talks, and this is a blurry picture which led to a bright future for congenital heart disease patients. And this is supposedly the first BTT shunt being inserted at Johns Hopkins. And as Victor pointed out, the mortality and morbidity has improved over the years, but we stand on the shoulders of giants here. What these pioneers had was the courage to be imperfect. They didn't They weren't aiming for perfection. They wanted to save a life, give a good quality of life, and in the best possible quality of life given the circumstances. So that courage to be imperfect hopefully is not lost upon us. So that being said, the tetralogy of Fallot, giving a brief history, this is the poster child of congenital heart disease because we had some interventional procedures initially for this particular lesion. And it wasn't really described by Dr. Fallot. It was described about 200 years before him by Neil Stilson in 1671. And Dr. Fallot described the same lesion about 200 years later, and this lesion came to be named after him. And nearly 300 years after the description of this lesion, we had something to do about it. That's pretty scary to think about in today's days and terms. But luckily, it didn't take another 300 years for the next innovation to come into effect. After the first BTT shunt, 10 years later, the complete repair of tetralogy is performed. And again, after that, it was in fast forward, the evolution of treatment of congenital heart disease. In the 1980s, we had surgery in infancy. And as recently as 2010, we had percutaneous valve implantation because when you do surgery in infancy, these patients are not fixed and they're never fixed. You need ongoing treatment with pulmonary valves especially. And then we had percutaneous options or so-called minimally invasive options. And even like this is 2 years ago, and our institution puts in most Harmony valves. This is a percutaneous valve, which is designed to be put in the native right ventricular outflow type position. And Dr. Morell showed some pictures of this. And I think Dr. Trucco can correct me. We are one of the highest implanters in the country of the Harmony valve. So what about survival? Survival is significantly improved. It is early mortality is, as you saw, it is 0% in our institution. It's below 3% in the registries, and it is largely determined by the severity of the lesion. Most importantly, there has been an error effect, again, luckily. So if you're operated on early on, or if you're born with the tetralogy of Fallot back in the 50s and 60s, if you see these papers are all based by decade. And as we have progressed in life, so has the survival. And now we almost, survival to adulthood is expected if you're born with the tetralogy of Fallot. This is a fascinating lesion, a transposition of great arteries, one of my favorites. And you're born with a parallel circulation instead of a series circulation. The blue blood comes, gets pumped right back into the body, and the pink blood comes from the lungs and gets pumped right back into the lungs again. You're running in circles, not compatible with life, obviously. So, and again, Victor mentioned this a little bit, but here's a pictorial representation of how the surgery for this has evolved over the decades. Initially, it was more of a physiologic repair where the blue blood was rerouted at the atrial level into the left ventricle, which pumped blood to the lungs, and same with the pink blood. And moving forward, they started doing an anatomic repair for various different reasons. The technology evolved, but they had the courage to be imperfect. They took a zero mortality surgical procedure and said, why not do something different, which is going to be better in the long term. Never would pass the IRB in this day and age, but this is where we are. So this is fascinating. You start with the same heart and you end up like either of these. But this era has ended. The era of the mustards and Sennings ended. So it was started in 1950s to 60s, and the last of these were in the 80s, barring very few exceptions. And so the patient age, this is a very tight cohort. That's what makes it interesting. The patient age is between 30s and 60s. If somebody tells you, I know how an 80-year-old mustard looks like, they're perhaps lying. And if they say, like, I know I've taken care of a 10-year-old mustard, it's possible, but rare. This is the era of the arterial switch now. The 1980s still, we don't know, like never say never again, okay? So the patient age is between 0 to 40s. Again, there are no 50-year-old arterial switch operation patients. So this data is evolving. So let's go through a couple of quick cases to see what happens to these patients when they grow up. This was a 49-year-old patient with transposition who had a mustard palliation, had the usual course, had a pacemaker for sinus node dysfunction, which is common. I see Gaurav frantically nodding his head, and that's where he comes in as the electrician, and Lee, of course. And had 4 pregnancies, did pretty well, and has been having some exertional dyspnea, and we sought some additional workup for this patient. And the transthoracic windows on this was quote unquote limited, and the baffle, which we saw at the atrial level, was reported to be patent or normal. But the exercise study, not so hard, only 17 ml per kilogram per, if I had to, this is about 50% predicted or even lower. So we ended up getting a CT scan, and which showed the baffle obstruction, which is another common sequelae of a mustard or an atrial switch operation. So what do you do with this patient? We got this thing. The only option probably was several years ago would have been going to an operation, but not so much now. Did some fancy, this pictures are courtesy of my colleague, Dr. Goldstein, 3D printing to look at the baffle. And here's him practicing the stent procedure, which is quite innovative. You'll see in a minute. And then went to the cath lab, confirmed the diagnosis. The injection from the top here is coming from the SVC and blocked. So it is decompressing all the way from below and kind of taking a circuitous route to the heart, not a very efficient circulation. So the 3D print model clearly helped. And this is a stent put in that baffle, a single stent, which is put in, taking care of both the IVC and SVC obstruction. And this is the final image, and going through the struts of the stent and expanded to go into the systemic ventricle. And so this is where we are. We can 3D print practice and go and deliver care. And what about arterial switch? We came up with this new latest and greatest procedure, and everything is going to be perfect. Not so much. Let's talk about this patient who is just 26-year-old with an arterial switch operation. When we say ASO, we mean arterial switch. It could be atrial switch, can get confusing, but this is where we are, contemporary surgery for transposition. This patient did have a severe aortic regurgitation, and that's a known sequelae, easy to see in an echocardiogram. So I ended up getting surgical aortic valve replacement for the severe aortic regurgitation. But he continued to have symptoms of fatigue and shortness of breath. And an astute resident listened to this patient because we have great residents at Children's Hospital of Pittsburgh, right? And had a systolic murmur, which is radiating to the right axilla. So most of the cardiologists in the room know where I'm going with this, and hopefully most of the residents too. So you don't have to be a cardiologist to know what's going on here, or a radiologist. This is the heart. This is the pulmonary arteries. They're pulled forward in a maneuver called Lecomte when they do the arterial switch operation, and it can get stretched and often narrow. You can see the right side of this is the right pulmonary artery, left pulmonary artery, that is narrow. That's a problem. We went ahead and got a lung perfusion scan to make sure all the data are coherent and adding up. You can see almost no flow going to the right lung there. This patient also ended up going to the cath lab, got a balloon angioplasty and a stent placed in the right pulmonary artery with amazing results. So transposition thoughts, the patients are aging out in the atrial switch, and we need to develop regional centers and study drugs which are variable response in this patient population, and a collaborative approach is important. And just because this is a tight cohort of aging out patients, we don't stop taking care of them or getting better treatments for them. We continue to do research. As far as arterial switch is concerned, the data are evolving, and the future of arterial switch operation remains to be seen. No talk on congenital heart disease is complete without a mention of Fontan. It's actually the Fontan-Kreutzer procedure. This was, though it was described first in 1969 and reported in 71 by Dr. Fontan, unbeknownst to him, Dr. Kreutzer on the other hemisphere did the same operation, similar operation with a slight variation, and they were unaware of the work of each other. And in many South American countries, all over the world, it is actually known as the Fontan-Kreutzer operation. If that name sounds familiar to you, it is because Dr. Jackie Kreutzer, who's our division chief, is the daughter of the original Kreutzer, who came up with this procedure. And to quote my good friend, Dr. Tarek, this would not have happened in 2023 because Tarek would have tweeted about this or X'd about it in about 5 minutes and published it in the next week when people would find out. So this procedure also has evolved over the years. This was in philosophy, it was rerouting the blue blood so that it bypasses the pumping chamber and goes directly into the lungs, and initially conceived by hooking up the right atrium to the pulmonary arteries. It has evolved with several variations with from left to right, the lateral tunnel, and now this is most commonly used as the extracardiac Fontan. So once a Fontan, this is like the 80-20 rule, where 20% of your patients take up 80% of your time while taking care of them. And still, we're learning a lot. There's still a lot of morbidity and mortality associated with it, because it is a staged procedure where initial Fontan circulation is a kind of compensated heart failure, where you go from there to decompensated heart failure. And then that's when I'm calling my transplant colleagues or interventional colleagues to help with manage and further palliate, and the ultimate pathway is transplantation for these patients. And to quote my friend again, I think Goldstein said this, or I'm going to give you credit anyway. Fontan is a human-made form of chronic heart failure. So ongoing care into adulthood is extremely important. Epstein anomaly, a rare form of congenital heart disease described by William Epstein back in 1866, where it's an abnormality of the tricuspid valve, where it is basically not functioning well and also displaced towards the apex of the heart. And this is making the small right ventricle severe tricuspid regurgitation. And the incidence is extremely uncommon. But why am I mentioning this here in a talk at UPMC? Because if you work here at Children's Hospital of Pittsburgh, you probably think Epstein anomaly is one of the most common forms of congenital heart disease. I'll tell you why in a second. And there's a range of severity and incidental discovery to death at the neonatal age. And again, extreme anatomic variability. The surgical techniques for this has also evolved with Danielson's technique in 1972, described at Mayo Clinic, the Carpentier technique, and the most contemporary of all, the De Silva cone repair. And if you look, these two faces again should look familiar to you, because we have the honor and privilege of both of them here, working at Children's Hospital of Pittsburgh, and that is the most contemporary technique, which gives a near anatomic result. What about the surgical outcome? Was Dr. De Silva, who is in the room right there, and was he perfect to begin with? I think he would like to think so, but not so much. He did have some early mortality, 3% to 4%, 3%, and re-repair of 4%. He admits that there was a learning curve, and the mortality has been improving significantly, so much so that we have had 0 early mortality at Children's Hospital of Pittsburgh since he got here about 7 years ago. Quite remarkable. And this is what we have at our hospital now. We have the De Silva Center for Epstein Anomaly. We get patients from all over the world. In fact, we meet twice a month. We are reviewing 3 to 4 Epstein cases. And some hospitals go by their entire lifetime seeing 3 to 4 Epsteins, but we we are reviewing this and operating. We get patients from Poland, and we got a patient from Singapore the other day, Middle East, all over the world. Quite remarkable. And a lot of talk on interventional management and surgical technique and hospital-based care. But remember that 99% of the patient's life is spent outside of the hospital. So majority of the treatment also happens in the less glamorous clinics where we are seeing patients. And so we need to study this. Though I'm dedicating just one slide for this, there are a lot of work going on with the medical management and non-invasive techniques to take care of patients with congenital heart disease. This study is led by my colleague, I think she's here, Dr. Sarah, who's a star researcher, and looking at medical management. It is hard to get a huge cohort of congenital heart disease patients to randomize and look at statin versus no statin or beta blocker versus no beta blocker. So we're kind of limited to adult literature, but we try to extrapolate some of that literature to congenital heart disease patients and continue to study them. And she's been leading efforts looking at the so-called GDMT or guideline-based medical therapy for patients with congenital heart disease with the latest and greatest interest on Jardiance. Does this work in our population? There were no significant changes. This is all just early data in some of the end organ function, but the NYHA class, which is commonly a measure of how well you're doing from a cardiac standpoint, improved in these patients. And also the echocardiographic parameters at the left and right heart function did improve. This is a mixed cohort, small numbers, but still important early data, which hopefully will guide therapies in the future. And there's some things. So coming on home stretch here, and again, getting philosophical for a second, this quote, we always say that the good old days, oh, remember the good old days. But that is just a factor of a bad memory. Nobody ever said, remember the good old days when we let all these congenital heart disease patients die. So let's go back there. No, we're not going to do that. We're going to move with the times. We're going to continue to innovate. We're creating this cohort of adult congenital heart disease population, which once you're congenital heart disease, you're always congenital heart disease. So it is our duty to take care of these adult patients with congenital heart disease. So why do we do what we do? We know the prevalence is 1% of congenital heart disease, and now there are more adults living with congenital heart disease because living longer, mortality is unexpected, and survival is almost a rule. And if this slide looks familiar to you all, it is because Dr. Dermody asked me for this slide for his grand rounds, and I made this for him, looking at the shifting demographics of congenital heart disease, which were mostly pediatric back in the day in the 60s to about half and half in 2000, but that is rapidly evolving. And now if you pick a population of congenital heart disease in the United States, most of them are adults. And this number is projected to keep increasing till 2050, because fortunately, we're not losing that many patients to mortality. There are more and more kids graduating into adulthood. And so if somebody's thinking of going into ACHD, it's a good time. So the numbers at CHP actually reflect that increasing or even better. This is the number of ACHD patients being seen with a 73% growth over the last 4 years. And why do we have to take care of these patients in a specialized center like ours? There are data. People have looked at it. This is an old paper actually from 2007 where they looked at what happened to patients who had ACHD who had lapse of care. And not surprisingly, but they proved it with data. It was a predictor of morbidity as well. And recently, we came up with accreditation of centers for ACHD. And this is just about 7 years ago. And then they went back and looked at, is there a difference in patients who were taken care of at accredited centers versus non-accredited centers? And they looked at just heart transplantation, and there was a significant difference. So we have convinced you these patients take a lot of resources. And what about one slide about the business standpoint for a hospital? And this was a study done by an independent consulting firm in an academic medical center similar to ours. And the red line is the clinical margin. And that's about 30%. If you're on the right of the red line, you're making profit. If you're left of the red line, you're a loss leader. So ACHT falls right there. And the conclusion of this consulting firm was that adult congenital heart disease is high volume and can be profitable. And CMS actually approved this as a specialty designation code just 3 years ago. So what we strive to do is build a single coordinated so-called tri-campus model. We cannot take care of these patients in a vacuum. It's a collaboration between Children's Hospital, Maggie Women's Hospital, where most of the congenital heart disease patients deliver, and Presbyterian, of course, and partnering with regional facilities and regional providers, of course, centered around the patient needs. So some of the quick highlights as a wrap up of the UPMC ACHT program. This is the only accredited ACHT program in the Western Pennsylvania. And as congenital heart disease has been consistently ranked in the top 10 by US News and World Report, and we continue to treat patients nationally and internationally. And this is our wonderful team. It's expanding. And in the 4 years, it's almost doubled in size, and we continue to expand and recruit. And as we move forward, I hope we'll continue to maintain the courage to be imperfect, and take our work seriously and not ourselves seriously. Thank you very much.